Way to go. Keep it going. Good job, guys. All right, Paul. I see you. All right, John. Finish on. Coach Carl. Great job, guys.
Hey there and welcome to episode 245 of the Today's Leader podcast. Today I share an amazing conversation that I had with David Contorno from E-Powered Benefits. Now, being from Australia, this was an incredibly fascinating conversation around the United States healthcare system and David's approach in trying to change it for the better for both patients and companies. It really is a fascinating conversation, highlighting to me that single people can certainly make a difference, especially when these single people find others around the country and together they can start to make a difference. Now, David has spent 21 plus years in the employee benefit space, and our conversation highlights his new way of thinking, which is certainly outside of the box in this transformative time for health insurance and employee benefits. E-Powered Benefits, David's company, are an agency specializing in networking with employers that truly care about their employees, but recognize the need for creative solutions that help bend the trend on rising health insurance premiums and at the same time increase employee satisfaction with the benefits packages that you are still paying a lot of money for. Now, David's conversation will certainly give you the trust and the respect in which he does this. And after a word from our network partner, I bring you David Contorno.
The Coach Curl podcast is brought to you by Think and Grow Business, the home of the Think and Grow Business Mastermind. If you're serious about growing your business, get serious and join a mastermind group today. Find out more at thinkandgrowbusiness.com.au.
It's my pleasure to welcome to today's podcast. I've got David Contorno. Now, have I said that right, Dave?
You actually did, and many don't. It's pretty simple if you break it down, but it's a good Italian name.
Excellent. Tell me the David Contorno story.
Well, I grew up outside of New York City, and maybe due to a parent's divorce, I started in the insurance business when I was 12 years old.
Wow.
Wasn't fully legal. I was telemarketing for life insurance under the table, but I was pretty good at it. I wound up getting into photography for a few years. I went to college for that. It turned out to be more of a passion than a career. And when I was 17, that was when I actually started doing health insurance for small and medium-sized businesses. And that I'm 43 now, so that was some years ago. And you know, at the time, at least in America, half of America gets their health insurance through their employer. And we have these large insurance companies that provide insurance. And I started to try and present to employers the best option for them to get the business. And then the way that I was paid was a commission. So if they were paying $1,000 a month in premium, I got a percentage of that, and all worked out good. The problem came many years later. It took me a long time to understand that I was part of what ultimately was a degrading and inflating healthcare system in the US. And the statistics that really started to speak to me were things like this. The World Health Organization ranks our healthcare system from a quality perspective 37th. We're tied with Slovenia for the quality of our healthcare system. And that's even for Americans, they think erroneously that we have a really high quality healthcare system. And that unfortunately is not true. It's actually one of the worst. And part of it is because of how doctors and hospitals are paid. They're paid on quantity of care. The more care they produce, the more they make. And the problem with more care is that's not good for the patients. So I started to say, wait a second, this is getting more and more painful year after year. And here was the worst part. And this is really where this awakening occurred.
Yeah.
I realized that the worst job I do at what my clients really need, which is lowering their healthcare costs, the more money I make. Because see, as a commissioned person, the more their rates went up, the more my revenue went up.
Yeah.
And it was that awakening, which occurred about 7 or 8 years ago, that I said, wait a second, I've been asking for years, what's causing this degradation of quality and inflation of costs? And everyone points the fingers at everyone else. I said, what can I do to change this? And what changed my entire world was changing how I get paid. And I went to my very next client and I said, do you know how I get paid? And they said, well, I guess you get something from the insurance company. I said, yeah, I get a commission, which means as your rates go up, I make more, but I get more than that. I get these amazing trips and dinners and golf outings to Ireland and private cruises, because the more business I put with a carrier, the more I keep with that specific carrier, the more money I make. And you don't know any of that. So what if I stripped all that out? What if instead you paid me directly? Because you think I work for you, so shouldn't you be the one paying me? But I like getting those bonuses. So I'm going to lose those if I start truly doing what's in your best interest. So what if you give me a bonus when I accomplish what you want me to accomplish? And I remember the client, he said, I love that idea. I said, great, let's do it. I said, good, what do you want me to accomplish? And he said, I want you to lower our healthcare costs. And what I realized at that moment was, for the last 17 or 18 years, I haven't been in healthcare. I was in health insurance.
Yeah. Yeah.
And purporting to lower healthcare costs by changing insurance is like expecting to lower your car payment if you switch from Allstate to Geico. Your car payment doesn't change when you switch car insurance carriers. You might save a little bit on your insurance, but you have to actually improve the car. And what I became is someone who actually understands how healthcare is delivered and paid for, and fundamentally changed that. And that changed everything.
Wow. And here I am sitting, I'm sitting here in Brisbane, Australia, and I'm still at that, the way that you guys do healthcare and the way that we do healthcare. So to my Australian listeners, they're probably sitting there going a little bit all over their head at the moment, but the American listeners are tuning in here. So I think that that's an important thing. It's two completely different healthcare systems, what we see in our country, and the majority of the healthcare, I'm presuming, in America is driven through the employer. Is that right?
Yeah, about half of Americans get it through their employer. The other half is a combination of government employees, veterans, and then Medicare, which is for the elderly, and Medicaid, which is for the low income.
So with the shift in your mindset, and I guess with that, your payment model, what's happened since then? So when did that happen, David?
That was about 8 years ago or so.
Yeah.
Yep. And what happened was, so listen, I speak and write a lot, and it's usually within the industry. It's usually to other brokers and consultants like me.
Yeah.
And it takes a very difficult path to bring this. And the reason why is, in this country, at least, people confuse healthcare and health insurance. Yeah. And if I ask most Americans who their healthcare provider is, they're going to give me the name of their insurance company. Meanwhile, most insurance companies don't provide any care at all. They just provide the insurance for it. And the care is really provided by doctors and hospitals. But when you start to dig into how doctors and hospitals are paid, just like I was paid in a way that was contrary to the interest of my client, doctors and hospitals are paid in a way that's contrary to the interest of their client, which is the patient, right? So there is a really dysfunctional methodology in our country, and this is kind of the way I codify it as simply as possible. A lot of people in the US think that our healthcare system is broken, but it's actually not broken. It's working exactly as it was designed to work. It just wasn't designed by employers who foot the bill, doctors who provide the care, or patients who receive the care. Another statistic that I find very frightening is that doctors in the US are the #1 suicide rate and substance abuse rate of any profession. It used to be dentists, but doctors overtook dentists. And when you ask doctors, why are you so depressed? What is causing this? The #1 answer is they're spending 40 to 60% of their time filling out paperwork for either the health system administrators or the insurance carriers to get paid. Now, I didn't go to medical school to spend 40 to 60% of my time filling out paperwork. I want to be treating patients. And even worse, if you look at a primary care doctor, the one you're supposed to go to first, and especially if they're part of a large health system,
Yeah.
they're paid in two ways. Two things largely determine their pay. Number one, how many patients they see in a day. The more patients they see, the more money they make. The problem is the more patients they see, the less time they spend with each patient, right?
Yeah.
And then number two, and this is, I challenge any American to ask their primary care doctor if they receive compensation based on something called an RVU. And an RVU stands for Relative Value Unit. And it's a measurement of how much that doctor is generating in other parts of the healthcare system. So if I'm a primary care doctor, Tony, and you come to me with, let's say, back pain,
Yeah.
my most profitable path by far is going to be, hey, let me write you a script for that pain. I want to get you out of the office as quickly as possible because I got to see those 30 or 40 other patients today. Let me refer you to a spine surgeon. And when you go to a spine surgeon, I don't care what's wrong with you. What do you think the most likely outcome is going to be? Spine
Possibly surgery. Yeah.
Yeah. And spine surgery is one of those areas where the number of surgeries that are done in which the patient either doesn't get better or gets worse is the majority of cases. So what I've done is I've given you a pain medication to get you out of the office as quickly as possible, in which we have an opioid epidemic in the US. And the most common start of an opioid addict is a legitimate prescription taken as prescribed and paid for by their employer's health plan.
Yeah.
Then I get you to that spine surgeon where your most likely outcome is going to be an $80,000 spine surgery. And the most likely outcome of spine surgery in the US is a second spine surgery. So I've maximized my revenue as the doctor by filling that path. Now, there are some doctors out there, no doubt, who say, I don't care how I get paid. I'm going to do what's right for the patient.
Yeah.
But what I believe, and I was starting to say this before, I speak to brokers and consultants like me all the time. And do any of them intentionally inflate costs for their clients? No. But when I changed my revenue model, prior to that, I had a box of solutions that I would go to because I knew I'd get paid from those solutions.
Yeah.
When my client was paying me, that box completely disappeared. And it didn't matter where I go as long as I achieve the goals the client wants me to achieve.
Yeah.
And there's a movement of doctors in the US that are leaving the traditional system. It's called direct primary care. And they are going out, leaving the traditional health system, never touching insurance again, charging a flat monthly fee. And it depends on geography, but it's anywhere from like $40 to $120 a month. That covers all of your primary care. And now the doctor doesn't have an incentive to do as many things as possible and get you out of the office as quickly as possible. As a matter of fact, they have far fewer patients because they have this dependable monthly stream of income that they don't have to see you or poke you or prod you to get money on.
Yeah.
And now we've turned the tables around on how the doctor gets paid.
Wow. It sounds like it's a bit of a revolution there, Dave.
It's really exciting. And what winds up happening is the patient feedback from this model in terms of the quality of care. And I myself have a direct primary care physician. So for me, when I need care, my doctor knows me intimately because he only has a few hundred patients instead of a few thousand. In the US, and this has changed a little bit because of COVID, what I'm about to say, but in the US, if you called up your primary care doctor and said, I'm a female, I have a urinary tract infection, I get a couple a year, I just need an antibiotic, they're going to say, you need to come in. Because they don't get paid by the insurance company unless they come in and you actually create the codes and submit the claim.
Yeah.
The problem is it's typically 21 days in the US. We have a shortage of primary care doctors. So the average wait time from when you call up to when you get to see the doctor is 21 days. And when you go into that doctor, you're going into an office with people who have the flu, maybe COVID now, all these other conditions. You're putting yourself at greater risk. Also, the doctor can spend 4 minutes with you to write you the prescription for the antibiotic that you knew you needed to begin with. In a direct primary care environment, because they're getting that monthly fee, regardless of whether they see you 1,000 times or not at all, they're like, oh, I know your whole history. I know every medication you're taking. I know you've had urinary tract infections before. Here's an antibiotic. I'm calling it into your local pharmacy. I live part-time in Portland, Oregon, and part-time in North Carolina, and my direct primary care doctor is in Chicago, Illinois. I don't need to see him except maybe once a year, and I get the best health care possible.
So the direct primary care is taking the place of insurance?
It is not all of it, but the statistics are that in a properly functioning primary care home, that doctor can do about 82% of the average American's care.
Wow.
So we still have 18% where you truly need that specialist. Like if you're pregnant, you need to go to an OBGYN. If you have cancer, you need to go to an oncologist. But things that we go to specialists for now in the US, you don't really need specialists for unless you're really a severe case. And I'll give you an example. Diabetes. You don't need to go to an endocrinologist if you have type 1 controlled or type 2 controlled diabetes. You don't need to go to a specialist for mild depression or anxiety. Your primary care doctor is fully capable of diagnosing and treating those types of conditions. So it's really putting as much care into that. And the difference between a primary care doctor and other doctors is that a primary care doctor is a diagnostician. Their primary role is to figure out what is wrong with you. And then if they're capable of treating it, they enact the treatment. If not, they send you a specialist who's not really a diagnostician. They're really treatment practitioners. They're the ones who fix the problem, not figure out what the problem is.
I'm just sort of sitting here thinking that it's like bringing the subscription model that we see with the Netflix of the world into the medical world, which is quite innovative. So how long has that sort of process been going on, the direct method?
It's been a really slow road because in the United States, if the first primary care doctors to do this, and one of the first was a gentleman in Nebraska of all places. His name is Dr. Josh Umber. And he had a little tough go of it at first, from my understanding, because if I am an individual who's working and covered through my job, I have the ability to just go to a doctor and pay a small copay. That's the average way that most Americans expose themselves to their share of the cost. So they might pay, the copays have gone up over the years, but they might pay a $30 or $40 or $50 copay, and the insurance pays the rest, whatever that additional cost is. And imagine for a minute, if I am an employee, I have money coming out of my paycheck. So for people outside of the US, typically the insurance has gotten so expensive that employees and employers share the cost. So if I sign up for a plan through my employer, I have some amount of money coming out of my paycheck every week, whether I use the insurance or not. And then when I go to use the insurance, I have a copay or some deductible, some exposure to cost up front on top of that. So imagine if I'm exposed to all that and I'm the average US worker. And then maybe I realize how low quality the care is in the US. And so I go and seek out this direct primary care doctor. And then they say, well, great, we're going to be, another $80 a month. And I'm just like, what? I can't afford that. I already have $200 a month coming out for my health insurance, and I have a $5,000 deductible when I actually use it. And now you want another $50 or $100? There's no way. So it was a really slow go. But a couple of things occurred in the US. Number one, doctors started to get so frustrated with how they were paid and the way they were treated that more and more went to primary care. So the collective knowledge of it and awareness of it went up. And then I know your podcast is on leadership, and I don't know if this is a version of leadership, but to my knowledge, I was one of the first people to build direct primary care into a customized employer plan, which is all that we do. We just started doing direct primary care bolted in. And I will tell you, we have one client that's a county, a municipality, and we lowered their total spend, and this was not even our best performing group, by 22% from what they were paying with the traditional carrier the year before. But what was really interesting was when we build the DPC plan, we actually allow employees to choose. Do you want to go to any doctor you want, or do you want to have to go through this primary care home? And for the ones that chose the primary care home, even though we had an additional fixed cost of that $50 or $100 a month on top of what everyone else had, these people still ran at 16% less expensive than these, because that monthly fee was covering so much more care instead of pushing them to those much more expensive specialists. And I'll give you one example of that same client. And again, it's a testament to how broken our healthcare system is, but we found when we took over this plan that with the old carrier, there was a spouse of an employee that was taking a very expensive cancer medication. It was $100,000 a month cancer medication. And we get proper clinical nurses in our plans to look at this. And they called up the doctor and they said, hey, doctor, you're treating this patient for this amount. And we see that you diagnosed them with this. and you're treating them with that. Both the manufacturer of the drug and the U.S. Food and Drug Administration say that in order for that treatment to be accurate and that diagnosis to be proper, certain tests needed to be done. You've had this person on this medication for 18 months. Can we please see the pathology for the labs that you did 18 months ago to indicate that this was the proper treatment and proper diagnosis? And I actually heard this call, the recording of it. The doctor said, I have been treating cancer for 30 years. I have seen this cancer hundreds of times. I know exactly what it is. I know exactly how to treat it, and they're on the right treatment. Now, I'd like to side note, in the 18 months they were on this treatment, their tumor shrunk not at all, zero. Yeah. We said to that doctor, listen, we really hope you're right, but we're not paying the $100,000 a month unless you get the pathology that the drug manufacturer and the FDA says is required. So he did it. He was forced to do it. He's going to lose $1 million a year if he doesn't. Yeah. Well, guess what it showed? She didn't have that type of cancer. The type of cancer she did have required a much less toxic treatment that only cost $10,000 a month. And the last time I checked, which was last September, so a year ago, which she was on the new treatment for 9 months, her tumor had shrunk 75% for the first time ever. Wow. So we saved the employer, over $1 million, and got the employee to a much better place of care and got their cancer properly treated. I mean, it was truly, except for the doctor maybe, it was truly a win-win-win situation. And in so many ways, that's frightening. So it is. And, I mentioned the spine surgery and how the incidence of unnecessary spine surgery, but in the U.S., the incidence of mistreatment and misdiagnosis in cancer is even higher than orthopedics. Wow. So who would you describe as your ideal customer, the client for yourself? Honestly, it's an employer who has employees, who cares about their employees, and who is a strong leader, because this type of change, and I don't know really how it is for other countries, but in the U.S., we hold on to our health insurance like for dear life. I mean, the whole Obamacare thing, and I say to people all the time, if you think Obamacare caused or fixed the problem, you don't understand the problem. All that Obamacare did was reform insurance. But Tony, I don't know what it's like in Australia, but if you called and wanted to get a price on knee surgery here, what is it going to cost? You can't get a price. You literally can't get a price. And part of the reason is that hospital and doctor might get 40 different prices depending on if they come in with a Blue Cross ID card or a United ID card or a Cigna ID card. There's going to be all these different prices. And so they usually don't know. And listen, I don't care what kind of business you're in. If your customers are not demanding a price prior to doing services, and they're allowing you to charge whatever the heck you want after services are rendered and payment is now obliged, they're going to raise the prices. I mean, if a restaurant didn't give you the price of the burger until after you consumed it, maybe they'll charge the same price on day one, but come day 5, they're adding 50 cents to that. And day 10, they're adding $1. And all of a sudden your burger's costing $300. It's one of the things that I've always been mindful of. My wife Sharon and I go to the States fairly regularly. We try and get over there at least once a year, except for, of course, for this year. But that health system has always been in the back of the mind of, my God, what's going to happen if we do get sick over there? And I know that we've got travel insurance and whatnot, but just that misunderstanding, I guess, and not being aware of how the system actually works. And, having a number of Aussies over there that work there tell me that's one of the biggest things when it comes to job negotiation, the deductibles and, what they pay, and so all of that. So it really is quite illuminating, this discussion that I'm having, David. So who else does what you do? So I can see that you've got a really altruistic. You're working in a way that helps and supports your clients, which is the employer, which ultimately is providing a better standard of care for the employee. So who else is doing what you're doing, or are you sort of the lone ranger in this? I actually wrote an article, I think it was in 2015, where I felt so alone up until that point, and I finally felt that people were coming to the island. But There's a few ways that we push this through the country. I think the most predominant way is a nonprofit organization that I'm a part of called Health Rosetta, and the website is healthrosetta.org. And I was, I think, among the first to be involved after the two founders, Dave Chase and Sean Chanson, and they were both in both legal and healthcare, but on big business. So Dave Chase had actually helped Microsoft found their healthcare business unit, which he helped grow to a multi-billion-dollar business unit. But it was through that he realized how broken the healthcare system was. And so he created Health Rosetta because the Rosetta Stone helped us decipher the hieroglyphics, and this is meant to help us decipher healthcare. And he started off, before he even contacted me, he started reaching out to some big businesses. And one of the businesses he reached out to was Walmart, the largest employer in the US.
Yeah.
And he got in touch with a guy named Tom Emmerich, who was running the Walmart health plan at the time. And what Tom Emmerich did was he would notice, and there's a lot of truth to this, that 5 or 10% of your population is driving 60 to 80% of your costs. They're the chronically sick, obese, diabetes, whatever.
Yeah.
So and transplants. Actually, that was what he started with, was transplants, liver, lung, heart transplants. They were being done in places you have no business getting it done at for astronomical costs. And so he started to seek out what he called centers of excellence. So Cleveland Clinic doing heart surgeries, transplants, UPMC doing liver, wherever was the best place to go. And then he'd call up and say, hey, I'm Walmart. We're going to fly patients out to you because you're the best. I want a pre-negotiated bundled price that's transparent and fair and honest. And if you give me that fair price, we will send patients to you constantly, no matter where in the country they're coming from. So he started to focus on what he calls the outliers.
Yeah.
And it saved Walmart a ton of money. So Health Rosetta said, well, let's look into that and let's verify, number one, that that's really saving money. And if it is, let's find other employers that are doing other things. Let's validate those. Let's put it together. Let's package it in a way that advisors and consultants can actually bring it to employers, and let's bring it down to the smallest of employers that we possibly can, to as many people as we possibly can. And so through that organization, we now have 240 advisors like me that are certified Health Rosetta. About 2.4 million Americans are on one of these Health Rosetta style plans. So that's one organization. And on healthrosetta.org, you can see all the advisors that are part of it, learn more about the program. We helped author a book on this.
Yeah.
And then as part of my own company, which is called ePowered Benefits, we work with employers directly, which was kind of what I've been discussing up to this point. But we have another division of our company in which we mentor brokers and consultants around the country in how to do this for their clients. And the model kind of is, we want to get you to do the first 4 or 5 or 6 with us. And once you feel good enough to do it on your own, go do it. We have 2 asks. Number one, when you feel good enough to teach someone else to do it, you do that. And if you learn something new along the way, you teach it back to us. Those are our 2 asks. So we do split the revenue on the cases we work directly, but once they're good enough to go on their own, we don't take a piece of that. And that's theirs. So trying to create, I'm a big Simon Sinek fan, and he talks about, the best leaders in the world don't have the most amount of followers. They cultivate the most amount of leaders. And I really subscribe to that. This is not about me being a leader. This is about me finding as many other leaders as I possibly can.
Yeah. John Maxwell also talks about one of the biggest aspects for leaders is to develop other leaders. So, and what I'm listening to, David, is a true leader. You've taken something for the greater good and really started to drive that individually, and you found like-minded people as you've come along. So congratulations. So apart from Simon Sinek, who else has inspired you in this journey of yours?
Well, I will tell you, there's a lot of people that have not heard of this man, but a lot of people have been impacted by him in the U.S. And his name is Dr. Marty Makary, Makary.
Yeah.
He's actually pretty well renowned. He's written a couple of books. His most recent book is called The Price We Pay. And what he talks about is the abusive and egregious billing practices of large hospital systems. So in the US, the most common type of plan, health insurance plan, is one in which there is some sort of upfront out-of-pocket cost to the patient, especially for hospitalizations.
Yeah.
And because insurance rates have gone up, those out-of-pockets have gone up because it's a very broken strategy, but it's a very short-term strategy that does bring your increase down. It doesn't lower your rates.
Yeah.
It just brings you, instead of a 15% increase, you raise your deductible a couple $1,000s for each one of your employees, and it might make it a 9% increase instead of 15. But as these deductibles have gone up, and listen to this waterfall effect here.
Yeah.
As deductibles have gone up, hospitals don't typically collect deductibles up front. Why? Because they don't know what it's going to cost, so they don't know how much to collect. So hospitals typically do the service, they bill insurance. Insurance says, here's how much we're paying you. The patient owes you $5,000. You go bill them and you deal with them. Well, the average American has about $500 in their savings account.
Yeah.
So when they bill that $5,000, as those deductibles have gone up, the amount that the hospitals have written off as bad debt has also gone up.
Yeah.
So they're trying to collect this money from the patient, ever increasing amounts. And there are hospitals out there that even though they may have gotten $50,000 or $100,000 from the insurance company, they were taking everyone, some hospital systems, one in Virginia, UVA Medical Center, was taking every patient, to court. The lowest amount that we found in the court records was $1.38 they sued somebody over. $1.38.
That's horrible.
Do you know they even sued their own employees? So if one of their own employees came into their health system for care, they had a deductible themselves, they would sue their own employees. Now, here's what happens. When you sue somebody in America in civil court, if that other person doesn't show up to court, the judge issues a summary judgment against the defendant. So basically they say, you didn't show up, we're giving everything to the plaintiff they asked for.
Yeah.
So that hospital now garnishes the wages of that already low paid employee, puts them in even more financial hardship. They still wind up not collecting all the money. So what they wind up doing next year with the insurance company is they say, listen, because you're slinging all these high deductible plans, we're writing off more and more bad debt. And because we're writing off more and more bad debt, we need an increase in our reimbursement rates. Now, I'm going to explain in a minute why insurance companies like increase in insurance in reimbursement rates, because most employers think, oh, insurance companies fight to keep rates down because the more they keep rates down, the more profit they make. No, I'm going to tell you why that's not true in a minute. But when the insurance company agrees to raise the reimbursement rate, a year later, that means that employer is going to have a raise in their increase in their premiums.
Yeah.
And because their premiums go up, their broker, who doesn't know how to do these types of strategies, says, well, the only thing I can offer is let's raise your deductible even more, which exposes the employee to more out of pocket, which has the hospital writing off more bad debt, which means they need higher reimbursement rates. Boom, it just goes around and around and around. So this is really important for any American to truly understand. Most employers think that if I send my insurance company $1 million in premium for all my employees, the less money they spend in care, doctors, hospitals, and prescriptions, the more money the insurance company makes.
Yeah.
Now, that's never really been true. But when Obamacare passed, there was a provision of Obamacare, which the real name for those technical people is the Patient Protection and Affordable Care Act.
Yeah.
PPACA or just ACA, oftentimes. There's a provision of that called the medical loss ratio provision, or the MLR in the industry. And what the MLR says is that every insurance company must spend 85 cents of every dollar they collect on actual healthcare costs. So 15 cents is what they get, 15% is what they get to keep for their overhead and their profit.
Yeah.
Okay. Well, that means if they have to maintain that 85% ratio, that means that as claims go down, their revenue goes down and their profit goes down. And most health insurance companies in the US are publicly traded.
Yeah.
And if you're a publicly traded company, you legally and fiduciarily serve one person and one person only, and that's your shareholders. And your job is to deliver as much profit as possible. So if you did lower healthcare costs, you'd actually violate the one responsibility that you actually do have legally to your shareholders.
Wow. Most of our hospital system is in the public arena and being run through various levels of government. So we do have a private sector, of course, but it's very much not in comparison to the public. So also it's just mind-boggling listening to this. So one of the questions that's coming to me is that the whole process of Obamacare, for example, becomes a bit of a political football. It gets booted from side to side. So the methodology and the model that you're talking about, how is that the same sort of style of political football, or is it immune from politics?
Well, it is immune from politics, I think, at least traditional governmental politics, because we don't use any traditional insurance carriers. We actually build a customized health plan for that specific employer.
Yeah.
And so while we have to meet certain mandates of the ACA, and all of our plans do, because employers have certain obligations and individuals have certain obligations under the law, we're not subject to that medical loss ratio provision at all. That only applies to traditional fully insured plans. So now when my payment model is such that the client pays me more as costs go down, I'm going to bring in every resource I can to achieve that goal. And they only benefit the more that we actually achieve that goal. So it gets us out of that. Now, if there's one area that I could believe that I'm truly a leader, it's not in the strategies I bring. It's not in the way we build plans. It's not in the way we get better care delivered. It's in the ability to get employers and then patients, employees, to think differently about how they consume healthcare. And, I'll give you an example. Listen, car salesmen have bad raps, I imagine, kind of universally, right? But there are good car salesmen out there, right? The opposite is true of doctors. For some reason in the US, and I don't know if it's exclusive to the US, curious if you have any feedback on it, but Americans put doctors on this pedestal.
Yeah.
And somehow they're no longer human, they're hyperhuman. And somehow they don't have bad days, they don't go through divorces, they don't have deaths or sickness in their family, they don't have financial issues. And we're gonna just trust everything they say to a much higher degree. And I remember I was in this client up in Massachusetts who we did the DPC plan. And I actually had the doctor come in to the employee education meeting, which in my opinion should be done all the time. If we're talking about healthcare, we should have an actual healthcare provider there instead of a health insurance expert. And there was this one woman that kept asking, well, who is he going to refer me to if I need a specialist? And I said, well, that depends on exactly what you need. And one example I gave is, if you are a 28-year-old former athlete and you need knee surgery, that might be a very different surgeon than a 64-year-old overweight female who needs similar knee surgery. So we literally want to be so hyper-focused on what is best for you and your state. And she said, well, how do I know how good those doctors are? And I said, that's a good question. How do you know how good your doctors are today? And she said, I went to their website. I said, oh, you looked up their bio that they typed themselves? I said, if they graduated last in their medical school, do you think it's going to say that on their bio? And by the way, what do you call a doctor who graduated last from medical school? Doctor. Yeah. So there are massive variations in cost and quality in the US, massive in healthcare. There's, literally, Tony, you can get an MRI for $300 or $4,800 on the same MRI machine.
Wow.
So I'll give the audience a little bit, and I'm happy to give as much, it's just we're constrained by time more than anything, but a little bit of our secret sauce in our plan. This is really how we do it. We create these relationships across the country of MRI centers, outpatient surgery centers, orthopedic hospitals, cardiac centers, where we know the quality in advance and we know the cost in advance. And one of the interesting dynamics in the US healthcare system is that cost and quality are inversely related to each other. The higher quality doctors and hospitals are almost always at the bottom of the price spectrum. The reason why? Frequency. The more they do a particular procedure, the better they tend to do it, the more efficiently they do it, the lower the price. So in the case of an MRI, if I'm the employer and my health plan is paying for this, would I rather them go to the $4,800 MRI where they're going to pay $2,000 and I'm going to pay $2,800 on top of that? What if instead I was able to intercede? And I said to them, look, you can still go to that $4,800 place, but we have a place down the road. And if you go to that place, I'm going to pay 100%. We don't say it's $300. That's irrelevant. Same machine. The results are going to get back to your doctor and you're going to pay nothing for that. I'll give you an example. I actually been getting some texts while we've been going on about a patient who needed a prosthesis implanted. He lives in Pennsylvania. He was going to go to UPMC, University of Pennsylvania Medical Center, which from a marketing perspective, everyone thinks is the best. When I called up to ask them, how well do you do this? They couldn't tell me. Luckily, I have access to that. It was a pretty low quality score. And then I asked, how much is this going to cost? The price they gave me was an approximate $97,000, not including anesthesia.
Wow.
Now, in comparison, he flew yesterday to Oklahoma City. There's a hospital there called the Surgery Center of Oklahoma. And if you go to their website, all of their pricing and all of their quality metrics are posted, not somewhere buried, but front and center on the homepage.
Yeah.
They're all in bundled price, including anesthesia, not an estimate, contractually warranted, $16,154.
Yeah, just a small difference, isn't it?
Right. So I said to him, look, this doctor is higher quality. The facility is higher quality. We'll pay all your travel, and you'll pay nothing if you go there. If you're going to go to UPMC, you're going to pay your $5,000 out of pocket.
Yeah.
And he flew to Oklahoma yesterday. So he's having the surgery tomorrow. So that's the type of stuff we do. And we create those incentives. So the benefit of those higher out of pockets that I was referencing earlier is the teeth for the average American to have that out of pocket waived is really high. And we know we're sending them to a higher quality or equal quality, but usually higher quality place of care. Now the employer looks like a hero because they're paying 100%. Nobody in America at this point has 100% paid for healthcare. And we're saving them, again, overall 30, 40, 50%, at least at the end of year one or year two. And then at some point we kind of reach the bottom and then sort of level it out. But it's really not that hard. So what I used to call myself for many years was a health insurance broker.
Yeah.
What I call myself today, and I don't think this would have made sense to anybody had I not gone through the last 30 or 40 minutes of explanation, is I'm a healthcare supply chain delivery manager.
Yeah.
I'm focusing on the healthcare side of things because if I can improve the quality of care and lower the cost of care, guess what happens to the quote unquote insurance covering that?
Yeah.
It gets higher quality and lower cost.
Yeah.
But in America, we've been trying to do it backwards. We've been trying to fix healthcare through health insurance. We can fix health insurance by fixing healthcare.
It sounds like there's like a system that sits there within the country that everyone just sort of accepts that that's the way that they've got to go. And then what I'm sort of seeing is, you know, whether we call it a little bit of disruption or someone that cares, someone that's looking at each individual case potentially and trying to get the best possible outcome, both for the employer and the employee. So, you know, kudos. So what does the vision for you look like? What does this thing look like in 5 years?
Well, so we've been doing it for 6 or 7 years now. You know, my guess is it's quite a lot of fodder for the rest of the world. It's fodder for the country, and that is our current political climate and the upcoming election that's 4 weeks away. And, you know, one of the, we have a couple of possibilities, I think, and again, I'm not getting into what's right, what's wrong, what's best, but the reality is, I think if Trump remains president, we can pretty much be assured that nothing's going to change because he's been incapable of doing anything for the last 4 years. He doesn't even have a plan.
Yeah.
And if we get Biden, I think we run the risk of universal health care. If not him, if the Democrats pick up as much steam as they seem to be getting, and I don't know if Biden's radical enough, but if Bernie Sanders has some sort of protege, because Bernie's going to be too old to run after Biden, but you know, you get someone who's really that far over to that side, then we run the real risk of universal health care. And my problem with universal health care in the US is this. We desperately need health care to improve in quality and lower in cost.
Yeah.
I challenge any American to find one thing that our government has taken over in which quality has gone up and costs have gone down.
Yeah.
I can't find one. And so if that's desperately what we need, I just don't believe the government taking over is the right thing. What I would like to see as a government intervention, but I don't even want to call it healthcare policy. I want to call it basic consumer protections. In the US, when you buy a home or a car, there are disclosures that are required. There are alignments of your real estate agent. In 32 states, it's illegal for the real estate agent to represent the buyer and the seller. In the other 18 states, it has to be fully disclosed. In the US, they're required to give us the price up front of a house, of a car, of a meal, of a car repair. But in healthcare, there is no requirement to give a price. There is no transparency on quality. What I want to see is the government require every healthcare provider to publish quality stats and give an upfront binding price. And if that was forced, it would be so easy to build health plans that incentivize that high quality, low cost care. Now I have to find all these ways around it. It's constantly, the balloon is squeezed over here, it pops out over there. That's constant, and it can be quite grinding. Luckily, I have an amazing partner who really, I take a pretty hardline approach. I ask difficult questions. I make people uncomfortable. I've come to believe that people don't change until the pain of staying the same is greater than the pain of change. And we can wait for our healthcare system to collapse around us, or I can make you so uncomfortable with what you're doing today for things you don't know you're doing in most cases, that we bring that bottom up to you right now and get that change to occur now. My partner, Emma, takes a much kinder, softer approach, but still with the same methodologies and the same outcomes. So we can really kind of talk to two different audiences, but that's where I feel the most friction comes from, is getting the very people that I am trying to help, the employers, the employees / patients, to say yes to this. That's the hardest part.
Recently, I just emceed an event here in Brisbane where our version of the Shark Tank, we had one of the guys, Steve Baxter, and he's got a real belief that, you know, if governments really want to solve a problem, give it to the entrepreneurs to solve it. Give them the resources, absolutely, and get out of their way, because what we often see with bureaucracy and government is all these complexities and hidden agendas and everything that just ultimately adds cost and doesn't ultimately solve the problem. So give it to the entrepreneurs, give it to the business world, and allow them to solve the problem. Give them the resources to do it. And I tend to agree with you. I've never seen government actually resolve anything in a way that makes it a better place to be.
You know, it's interesting in the U.S., our healthcare system is so broken and so entrenched that 3 of the largest and most forward-thinking companies in the U.S. put money together to form a company specifically designed to fix healthcare. The 3 companies were Amazon, JP Morgan, and Berkshire Hathaway. So you got Jeff Bezos, Jamie Dimon, and Warren Buffett, right? I mean, 3 of the greatest minds in the world, perhaps. And they put all this money in to create a company that became known as Haven. And they picked a guy named Dr. Atul Gawande to run Haven. Now, they reached out to me. We had multiple conversations. I told them what they needed to do. Well, let's just say that 3 years later, Atul has stepped down. Haven has accomplished nothing of any note or notoriety. So even think about it for a second. United Healthcare is is the largest health insurer in probably the world, but certainly in the U.S. Imagine if United Healthcare, I'm sure, touches a piece of all 3 of those companies in a big way. So imagine if Amazon forms this company meant to disrupt a company like United Healthcare, and United Healthcare calls up Amazon and says, you know, we're sending you $1 billion a year for your Amazon Web Services. We're going to flip that over to Rackspace. And then they call JP Morgan and they say, you do all of our IPOs and investment banking and you make billions of dollars a year for us. We're going to pull that from you. So they have so much clout. They have lobbyists. They have committees, and it's just so difficult. And then add to that employers and employees are so scared to leave the traditional insurance system because they think somehow it's going to disrupt their healthcare. There is just huge, resistance to this. So we found the employers that really buy into this the most are blue and gray collar. And blue and gray collar is important because a lot of times those companies are being run by people that are also blue and gray collar. And maybe it's a family business where the owner's son is now running the business. And he used to be one of those blue and gray collar employees. So he knows everyone's name and their wives' names and their husbands' names and their children's names. They care about their employees. They walk amongst their employees. They don't sit in some ivory tower disconnected from what a $5,000 out of pocket is because they make $500,000 a year and can easily afford it. So it's those 100 employee companies, those 500 employee companies, those 1,000 employee companies. Those are the ones that are going to lead the charge. And Sean from Health Rosetta says it best. He says, we're not going to fix this with one 500,000 employer.
Yeah.
We're going to fix this with 500,000 or 5,100 employee companies from the ground up. That's what's going to fix it. So my biggest fear is if we don't have an impact soon in a positive, substantial way, the system's going to break. And if the system breaks, someone's going to pick up the pieces. It's most likely going to be the government. And I don't think any of us are going to like that option.
And it's interesting, the US healthcare is, everyone around the world has got a vision of it. And an interesting thing from my perspective is that but I was in Tokyo in March of this year, just as COVID starting to get going. And I said to my wife at the time, just like in a bit of a throwaway comment, more so than anything else, I said, I think the country that's really going to struggle with this is the US because of their healthcare. And like I wasn't being a Nostradamus, it was just a throwaway comment based on what I feel and think about the system. And ultimately, that's what's happened, unfortunately, whether it's been a multiple of factors. But anyway, David, we've just run out of time. It's been an absolute pleasure speaking with you. But before we go, I ask this of every single leader I interview. What's the book that's had the biggest impact on you during your career?
So I'm going to segregate that into two books because there was one earlier on and then one later. Earlier on, it was America's Bitter Pill by Stephen Brill, Brill. And he really woke my eyes up to this is a healthcare problem, not a health insurance problem. Yeah. And then the other book, which is much more recent, is it's called The Price We Pay by Dr. Marty McCary, who I think I mentioned earlier. And that will help you understand how broken the healthcare system is from a health system perspective. So how is it, the US is spending about 20% of our gross domestic product on healthcare. That is way more than any other country. And don't forget, we have a pretty large domestic product. So we're spending 20% of that on healthcare costs. Why? Where is all that money going? Who is really paying it? And what you find is the money is being paid by the masses and all the patients. The more ill you are, the more you're probably paying, whether you realize it or not. And it's going to the few. It's going to the hospital system executives. It's going to the health insurance executives. That's where the money's going to. So it's really the people that are being hurt the most, but they don't even see it. You know why? It's the healthcare system that's sucking the value, but it's the health insurance system that's the courier of that. So we blame health insurance, but we feel we need it. We give a pass to the people really causing the problems because we revere them and hold them on a pedestal. And we're not really ever really addressing the issue. And those two books really helped me understand where is the problem. And even though it didn't give all the fixes, it directionally told me what to focus on.
Absolutely. How can people connect with you, Dave?
I think the best way is LinkedIn. So hopefully you'll put the spelling of my name in show notes. It's luckily unique enough that I'm pretty easy to find. I do put a lot of content on LinkedIn, and then anyone can message me through there if they want a more personalized conversation.
Excellent. No worries. David, it's been an absolute pleasure. Very eye-opening conversation for myself. And thank you very much for your time.
Thank you, Tony.
Join the group of people impacted by seriously simple stuff to get you unstuck. The first book by Tony Coach Curl. Available at Amazon, Tony's Simple Stuff provides the tool for people to master your life and aspirations. 20% of every book sold supports Carter's cause.
Now, one of the biggest takeaways I had during our conversation was the assumption that David sees himself quite reluctantly as a leader. He's driven by a purpose that came from his realization that he wanted to be a positive contributor to a healthcare system and not to be driven by a health insurance perspective. Now, as I mentioned in the intro, it's hard not to be inspired by the fact that one person can truly make a difference. And what came through in this case is that around America, there are a number of single people or single companies that are really looking to make a difference. And over time, they've come to find each other. And together, I've got no doubt that they'll be creating even more momentum and more impact to try and drive some real benefit into healthcare. Now, don't you ever believe that you cannot make a difference by yourself. Share your energy, drive towards your purpose, and along the way, you will find like-minded people, just as David has done. Now, in today's disruptive world, good leadership skills will always stand you in great stead. And if you're looking to build great leadership skills, there is no better time than now to check out the new Today's Leader website at todaysleader.com.au. Not only does it showcase our podcast, it showcases our magazine, and we're pleased to say that Think and Grow Business hosted masterminds are now available on the Today's Leader website. We are now supported by our network sites, all of which you can see on our website. So Today's Leader has become a collective mindset for the leaders and the entrepreneurs of today, forging the path of success for tomorrow. The mindset to make a difference and the ability to create an impact. Now, Think and Grow Business hosts our Today's Leader Masterminds, Think and Grow Business, where they focus on personal, professional and business growth. Book your free 30-minute discovery call now at thinkandgrowbusiness.com.au. Another one of our network sites, the Coach Curl Academy, has over 78 programs to help you build a better you. Join for just $1 for the first month. The academy that equips you and enhances your mindset, your leadership, and your business skills and knowledge. Check it out at thecoachcurlacademy.com. Don't forget, where you are standing stronger, braver, and wiser. Don't ever forget the golden rule. Yes, you know what that is. Just don't be an arsehole. I'll see you next week.